just as a brief introduction, what we're doing, this is our second hearing session in relation to the London Health Commission. Last week, we looked at the issues and the challenges in terms of the provision of high-quality care in London, and certainly was a very rich discussion during the morning, and we learned a lot from that. And the afternoon, we spent a significant amount of time looking at the health and wealth agenda, and also that was another very, very rich discussion, and I very much hope that today will be the same. So we have two themes. This morning's theme is about enabling. It's about enabling high-quality care for all, but it's also about enabling of integration. So there are some major, major challenges facing those who speak about policy of integration in terms of workforce, in terms of state, in terms of the regulatory framework, in terms of leadership. So we're trying to tease out today from the experts who are, given a lot of their time to be here, both from the UK, London, and overseas, and in really going in depth and see what is the evidence-based, what could London Commission do as far as integration is concerned. So before I introduce our first witness, I'd like to introduce our expert panel, and also very, very grateful for them to take the time and spend their day with us. On my right is Anne Brainsbury, who is the head of NHS England in London, and on her right is Jeremy Taylor, who is the CEO of National Voices. As you all are aware, a very important component of the London Commission is not just to, just listen to patients at a national level, but we're also gone very, very deep within London as well, with the help of Jeremy, understanding what are the specific Londoners' needs as far as the public and patients. On my left is Andrew Ridley, who's very kindly is actually the chair of this session, and I'm very grateful for taking the time and the leadership in driving this. And then the person who needs no introduction, who knows more about London than anyone I know, and that's Sam Everington, who is a wonderful colleague and a general practitioner, runs a very innovative, integrated practice. Most of the CVs of the panel are on the website, so I'm not going to spend much time going in depth with them. And let's move on to our first witness, who's Candace Imison, who I've known for a long time, who's currently working in the King's Fund. So Candace, if you wouldn't mind. Candace, the way we're doing this today is we're just going to give you a few minutes just to give us your own thoughts and views about the Commission, and more specifically about this theme. What could we do about enabling integration of care and enabling the provision of high-quality care? And then after that, we'll be asking you some further questions, and thank you very much for being here.
It's an absolute pleasure, Ara, and welcome to everyone here. So I want to begin with some comments that straddle all sectors, and then I was actually going to dive down into some of the issues that are specific within different areas across health and social care. So I think the first point to make about integrated care is something that Liz Pace, who, as you know, has led the work in North West London on integrated care, makes, is there's no such thing as seamless care. The point is to have really tight seams. And I think all too often we try to create these sort of organisational models, these great complex things, when actually some really close attention to the inevitable seams that will exist between services would really help us all. And we don't do that, and as a consequence, patients, people can feel very lost in those seams. They can be a very distressing place to be as you're handed off from one service to another. And it goes without saying, from my perspective, that information technology, just as well as the way that people behave, is going to be a real key bridge to those themes, and I'm sure that will come through as a major theme this morning in the evidence that you get. A little word of caution about the financial context. I don't think I can speak this morning without recognising that and the fact that it is going to get worse, and that as it gets worse, that may drive behaviours that are not about working together. It may drive defensive behaviours. So that leads me to my third overarching point, which is that the importance of culture and actually working in an environment where everyone feels they are in this together for quality. And at this point, Ara, I'd like to pay huge recognition to the work that you did when you were at the DH in setting a culture that was about quality. And I think in London, if you can do the same, then that will be enormously helpful and important. So I just then thought it might be helpful to dive into some of the sort of sector-specific issues and how they arise. I suppose, too, before I do that, again, a sort of an acknowledgement that actually if we're serious about improving health outcomes, that this is about public health, and actually the work that the local authorities are now setting off and doing through their new responsibilities there is incredibly important. And I would point you to a publication we've just produced at the Fund called Improving the Public's Health, a Resource for Local Authorities, which is really trying to help them maximise that role. So my first stop is primary care. And as Sam will know better than I, in my view, the key issues here are scale and scope, which are a major obstacle. The fragmented corner shop model of primary care does not facilitate either integrated care or good quality care. And we see massive variation in clinical practice, and you will again know this better than I across London, because London's done a lot of work to expose that. But I often reflect, if we had actually put as much effort into developing primary care, particularly around its role of chronic disease management, as we did into our stroke reconfiguration, how many more lives might have actually been saved through that effort. So really what we're wanting in primary care is it move to a more scaled and federated model is the term that the Royal College of General Practitioners uses. And I think that the vision that Claire Gerarda is starting to set out now for primary care in London is a really good one, and I would totally endorse it. I think absolutely critical is that federated model, though, has a population focus. And for me, a key theme across all areas is that if we have a population focus, that is a binding force for the conversation between different areas in the system. So if the federations are focused on a population, and likewise their neighbouring hospitals and likewise local social care, then we have a common purpose to work to. Another key issue primary care is going to face, certainly around quality, is issues within its workforce. And I would just encourage you not to forget that there are opportunities, significant opportunities in primary care to use other staff other than doctors to facilitate their work. A key barrier to integrated care is the confusing and complex array of services we see in community care. They are befuddling for patients, they're befuddling for professionals, and the evidence shows us that complexity is a real obstacle to them having the impact that they should have on other services. So we don't have single points of entry often. In fact, the sort of surreal example that I came across when I was doing work on referral management was a GP that told me he referred his patients into hospital because he thought they had more of a chance of understanding the community services than he did. So he's referring them into hospital in order to get referred out again, which is just mad. And community services too can be a binding force across the system, but all too often they're this sort of Cinderella service that doesn't do that. And they too have significant workforce issues. We've got a looming workforce crisis in terms of the age profile of staff, and we have underinvested in that staff group, so it's something that really needs close attention. And in a similar vein, social care, likewise, already faces issues in terms of recruiting and retaining staff, but those are only going to get worse as the population ages and needs more social care. There's actually one prediction that we included in our work on workforce, that we would have faced 1 million workers shortfall by 2025 in social care. And as the broader economy picks up, then those recruitment and retention difficulties might be expected to get worse. Mental health. Mental health really sadly now operates largely in isolation from the rest of the health system, and yet we know that people have mental health and physical health problems tightly wrapped together, particularly people with chronic disease. So there are huge benefits to be got from getting them to work, those services to work much more closely together. And it just seems mad. An example in the trust where I'm a non-executive director is that we have taken literally years to persuade the local PCT that we should have a liaison psychiatrist support people with dementia on our wards, when we have 50% of the patients on our wards have got dementia. It's a massive issue, and it really isn't appropriate that the services are as separate as they are. I was very struck. We did some work with King's Health Partners, and they were getting incredibly enthused about the opportunities that bringing SLAM closer together with their acute services might bring. And it struck me that the academic health science networks could be a real facilitator of bringing mental health more into the fold. So finally, secondary care. And this is really quite a sort of strong personal view, really, I think, but underpinned by evidence. One of the greatest threats, this is to quality here rather than to integrated care, is the reliance on junior doctors. We are relatively unique in this, as you know, across the world, by the fact that we attempt to train doctors in every single hospital and have doctors in training as our frontline of service provider, and we have got mounting evidence that of differences in outcomes between out of hours. And we know that having more senior doctors at the front line in A&E improve outcomes and the issues for patients. So this is something that really does need to be addressed, and London is particularly an area which is dependent on this.
Thank you. Thank you very much. I've listened to this all morning, and all very, very good stuff, but I just wanted colleagues to get the opportunity to ask some questions. Anyone on my right? Yeah, Jeremy.
What's to be done? I mean, what should this commission... I mean, you've taken us on a tour through a whole load of really wicked issues. I mean, if there was something this commission could recommend for London that would make a difference.
So I've got 3 top things which I was going to just get onto, but I think the cultural issue and a very heavy focus on quality improvement and giving people quality improvement skills. So the Don Berwick piece of giving people the skills and feeling that they should be improving their job at the same time as doing their job. I think there is imaginative stuff that you can do to reduce the reliance on junior doctors, which comes through extended roles, using for nurses, using people like physicians' assistants, having more managed clinical networks, and IT, as I mentioned earlier. And then my third point would be the piece around the population focus, really driving that as the common binding force across the different services.
What does that mean in layman's terms, a population
focus? So what it would mean is, say, that, I mean, exactly what you've got in Sam's neck of the woods, that everyone in Tower Hamlets is focused on what they can do for Tower Hamlets. The GPs, as a coherent force, are thinking about Tower Hamlets alongside the local authority, hopefully alongside your local acute provider. And there are really good examples emerging of particularly secondary care doctors, say in COPD or dermatology, taking a population focus for those groups of patients, working to skill up GPs, developing staff in the intermediate tier GPs with a special interest, again, to look at things from that population perspective, so that everyone is seeing that what I am about is improving care for this group of patients rather than my organisation, and just seeing it in those contexts.
Okay, thank you. Any other? Sam?
Just a quick one on primary care. Question of variability and also the role of primary care. And we know there's a great interest in doing more terminal care, proactive care of patients, less in hospital, more in the community, which a lot of patients would like to see. What 2 or 3 things would you do to primary care to get rid of the variability and extend their role into the role I described, but also actually into what I would call social prescribing, in other words, connecting it to the voluntary sector?
So that's where the federated model, in my view, is absolutely key, because you need a critical mass that is a group where you are then doing peer review and audit within that larger federated model. You've got an infrastructure in that model that then supports you to develop, say, the IT that you need, and that enables you to get some of the working links across with other services. Because while services are trying to relate to this multiplicity of lots of little units, it is very, very hard. Whereas when you've got a bigger cohesive unit to link to, it is made easier. Does that answer your question? I mean, you're not looking convinced.
The trouble is, it's an answer that you could go on.
Yes, yeah.
Okay. Thank you. Yes?
Just a quick question, I'm conscious of time. Candace, you didn't mention it, but in your report last year, the King's Fund, one of the things it argued for was a suspension of competition rules in London because there's a major barrier to integration. Is that still the view?
I think we are concerned that if you think about what the relative impact of different elements, ways in which you might improve services, the strongest evidence is for culture and quality improvement as a means of driving improvement. The evidence around the benefits of competition are much more equivocal and limited to certain service areas. So again, it's if you're going to have a bang for your buck, invest in culture and the intrinsic motivation within staff rather than competition.
Well, thank you for that. I really would love to spend all morning asking questions, but one of the things we've done is sort of seek your help and support. Your expertise, your background. If you can come back to us in writing on certain things, because you mentioned about junior doctors saying that not every provider should be training junior doctors, and more or less saying that that will improve the quality of care driven, but also probably will improve the quality of training to junior doctors. And I wonder whether you can expand on that in writing to us, because I think that's a very important point, because usually the domino effect starts with the junior doctors leaving. The second one you talk about is quality improvement skills. We've been around the block on this. We had that organisation 15 years ago, post-NHS Plan, Modernisation Agency was called, and we tried to reinvent that a few times, NHS III and so on and so forth. So do you think the university sector should be involved in this, considering, we make quite a big fuss of our universities in London, 3 of them? Should it be the academic sciences networks? Again, it would be wonderful to get some thoughts on that. And I think the competition thing that Anne asked is great, and if there's any further. But one other question which did come up last week, and that is, the King's Fund did make a statement that there is no leadership in London to lead this change. And what's the evidence behind that? I suspect you were talking at a time of transition. We do have a NHS England in London, which is a maturing organisation. CCGs will take a while to mature. Rome wasn't built in a week, and I just thought, if you can send me some further, have you changed your minds, or you still think that's the case, and will be extremely useful. So, thank you again for coming, and I'm very grateful for your time and the good work that the King's Fund does. Thank you.